Good morning, everyone. I hope you can hear me now, or good evening or afternoon, wherever you're joining us from. So we'd like to welcome you on behalf of the Global Tracheostomy Collaborative to our next educational webinar, Tracheostomy Care Management, What Patients and Family Want. So I'd also like to acknowledge and thank our sponsor, Medtronic, who helps us make these webinars a reality. So today in our webinar, we've got some aims which the speakers will cover in their sessions. So understanding the importance of giving patients a voice and humanising care, discussing the care supports needed after discharge from hospital, and examining strategies about incorporating tracheostomy to daily life and activity. Also how to analyse and build and establish those important community connections and to stay safe and healthy. So I'm Dr. Amy Freeman-Sanderson, one of the moderators for this talk, but also I'd like to acknowledge our wonderful panel that we have coming up. So we've got various professionals from across the globe. So Helen Newman, Dr. Eatonsbury, Barbara Bosworth, and Karen Ulmer. So I'm going to hand over to our other moderator and president of the GTC, Dr. Michael Brenner. You're just on mute, Michael.
Thanks so much, Amy. It's wonderful to have this outstanding group of panelists, the first of whom is Helen Newman. So Helen trained as a speech and language therapist at the Newcastle University in north of England. She has over 20 years of clinical experience working with adults with communication and swallowing disorders in the United Kingdom and New Zealand. She currently holds a National Institute for Health Research Clinical Doctoral Research Fellowship. This fellowship is based clinically at Barnet Hospital, part of the Royal Free London NHS Foundation Trust, and academically at the University College of London Division of Surgery and Interventional Science. The focus of Helen's PhD research is how to choose tracheostomy tube size for adults in critical care. She has also co-authored a book chapter on the power of communication in critical care in the speech language therapist pillar of the UK Intensive Care Society Allied Health Professionals Professional Development Framework. She's involved in the Allied Health Professional Critical Care Workforce Project and is a member of the International Group of Speech Language Therapists working in ultrasound. Helen is a committee member and treasurer of the Royal College of Speech and Language Therapy's Tracheostomy Clinical Expert Network. It's my distinct privilege to have her speak to our global audience on the importance of patient-centered and humanized care in the hospital. Thanks for joining us, Helen.
Thank you very much for inviting me to present. So today I'll be presenting on patient experience of tracheostomy, and I'm aware we've got a number of patients and their relatives watching, so I hope I do this question justice. I'm also aware that the talk may bring up memories of ICU experiences for people, and I hope that this is not too upsetting. So I'm presenting the first work stream of my PhD, which aims to generate knowledge on how to choose the best size tracheostomy tube for patients. So to provide good care for ICU patients with a tracheostomy, we need to know what matters to them. So this is the aim for the first work stream. It's a qualitative systematic review and meta-synthesis, which is a particular type of review method. Qualitative means it focuses on word-based knowledge, so mostly from open-ended questions and interviews. And this is the best way to get rich data from the patient's perspective on patient experience. The review summarised existing research, and the meta-synthesis was used to develop new insights and translate findings into meaningful clinical implications. Our analysis followed 3 stages of Thomas and Harden's thematic synthesis. To start with, we coded the data from the selected articles line by line, and then gradually teased out the themes that emerged from the articles, from the studies. And this produced the main descriptive themes and sub-themes, which are shown on the thematic map on the next slide. The QR code takes you to the protocol that's registered on Prospero, and the manuscript has been accepted for publication by the Journal of Critical Care, and it should be out this week. The writing's very small, but the 5 main themes were voice and disrupted communication, autonomy and self-identity, cognitive, psychological and emotional needs and experiences, physical needs and experiences, and facilitators to well-being and recovery. And I'll talk through each of these in turn. The sub-themes of the first major theme were how it felt to be voiceless in ICU, the limitations of augmentative and alternative communication, and speech functions and the impact of impaired communication. Patients spoke of fear, anger, misunderstandings and uncertainty because they couldn't speak, and of the enormous relief on return of voice. AAC was useful for some patients but often failed, and people preferred others to lip read. Loss of speech meant loss of social interaction, inability to call for help or ask questions, and an inability to be one's full self. Ian, pictured here, is an ex-ICU patient and part of my patient and public involvement group that have helped develop my research proposal. He very kindly sent me 4 pictures to choose from for this talk and labelled them full-on coma mode, ready for a nap, first time outside, and this one was awake but totally clueless. And I'd be interested to know if hearing his words has perhaps changed your first impression of him. Another patient helping the project told me of a time on ICU when she'd been in severe pain and she's getting increasingly frustrated but couldn't communicate it. And the nurse saw her as agitated and sedated her. So not only was her pain not detected, but she was given medication that can cause delirium and potentially impact long-term outcomes. The second theme was divided into self-determination and agency, and identity and connections with others. People with a tracheostomy reported being unable to participate in decisions, losing control over what happened to them, having to fight to be heard, or giving up and withdrawing. They felt anonymous, incomplete and isolated, and some felt they weren't treated as a human being. Having a connection with others was highly valued. So you can see that communication runs through this theme as it enables control, and a person's voice is seen as part of their identity. Theme 3 sub-themes were fear, anxiety and mental well-being, information needs and situational awareness, and the experience of time. People reported they were afraid of dying, of not being able to call out for help or get pain relief, or breathing tubes blocking. Tube changes were seen as routine by staff, but could cause anxiety to patients. Some patients recalled the shock of waking on ICU and not knowing what was happening, and difficulty in getting information or reassurance. And they found staff gave them less information when they didn't have a voice, and some staff didn't speak to them directly at all. The perception of time was different on ICU, and this might be due to poor sleep, confusion, lack of normal routine or structure, or simply boredom. And this was worse when patients weren't able to communicate. Theme 4's sub-themes were physical sensations related to tracheostomy and meeting physical needs. Thirst and swallowing difficulties were distressing to patients. The inability to eat, toilet or shower normally was seen as a deprivation of a basic human activity. Patients experienced pain at the stoma site due to suctioning or having a large tube, and discomfort on coughing and swallowing. And due to lack of speech, pain and other physical needs sometimes went unmet. And care was spoken of in 2 ways: competent technical skills of staff and compassionate attitudes and behaviour. And both of these were equally valued. Theme 5's sub-themes were improving communication, coping strategies and character traits, making sense of the situation, signs that indicate recovery to patients, and the essentialness of family and relationships with others. A PPI group member told me that getting her voice back was wonderful because I was treated like an intelligent person again. Where voice restoration was not possible, lip reading was valued higher than other communication methods. Coping strategies included setting and monitoring your own goals, drawing on spiritual beliefs, and the removal of tubes, starting to eat and drink again, and signs of returning to normal helped patients feel better. Good information exchange helped patients make sense of what was happening to them and make them feel more in control and more at ease. And the presence of family and friends brought comfort, and the family and friends could act as translators and advocates. Good staff-patient relationships were also really important in helping patients feel safe. And trust was developed based on perceptions of competency of staff, caring attitudes, and responsiveness to needs. Non-verbal communication was valuable here, so hand-holding, eye contact, presence at the bedside could make patients feel safe and well cared for. In the next stage, the metasynthesis was used to we used the descriptive themes to answer our questions, what matters most to patients. And this led to 3 analytical themes. Firstly, patients wanted to be seen as their unique self, not a body in a bed or a list of medical conditions, and they wanted to have a say in what happened to them. Secondly, humans are social creatures who need to make sense of things. People wanted to ask questions and be spoken to, but not just to explain procedures, they needed social connections. And thirdly, voice enables other goals, and it's integral to our personal identity. As unique as a fingerprint, packed with information about who we are, our age, our gender, where we're from, whether we're feeling happy, sad, or excited, or scared. Our overarching theme was to be seen and heard as a whole person. So in conclusion, we need to listen to what matters to patients in order to provide high quality care, both at a service level and at the level of the individual. Qualitative methods like those we used in our review can help us understand patient perspectives and identify person-centered outcomes. The review concluded that patients with a tracheostomy in ICU wanted to be treated as a human, and that having a voice made this easier. So what are the clinical implications in ICU? MDT training should focus on technical and compassionate aspects of care. We should screen for pain at the stoma site, stitches, and tracheostomy collar. Patient care should be holistic. Ward rounds and case histories should include information on the person as well as their body. If the patient is awake and has no voice, then we need to establish means of communication with referral to speech and language therapists as needed. Patients should be involved in decisions and given opportunities to ask questions with their communication supported as needed. We need to tell patients what's happening and how tracheostomy affects their voice, and we need to explain as many times as the patient needs. Time spent on social chit-chat is time well spent. It shows patients they're important, cared for, and valued. And we should encourage family visits where appropriate. We should give high priority to voice and consider it in any interventions that might affect it. And the MDT should be trained in supporting voice restoration and alternative communication options. Where voice isn't possible, we should make communication as natural as possible. For example, assigning staff who are able to lip read if the patient's able to mouth words. And don't forget non-verbal communication, including making eye contact, touch, being present at the bedside, all part of compassionate care. Staff and family need to check that they've understood the patient, so don't finish sentences or jump to conclusions about what the message is. It's incredibly frustrating for patients, and if you're using a spelling system, you have to write down what they're spelling because you won't remember more than 5 letters. And lastly, we need to give patients a call bell. So in a nutshell, give patients a voice. If you can't, then help them make their decisions and wishes known, connect with them, make them feel human. Thank you for listening.
Thanks so much, Helen, for really just a phenomenal talk and all the wonderful work that you've done in this field, which is so important. I think that many of us and many of those in the audience can surely relate to some of what you found in your study. And it actually made me recall back in the early years of the Global Tracheostomy Collaborative, we had the since deceased physicist Stephen Hawking as one of our keynotes in the United Kingdom. And he really highlighted a lot of the points that you raised, that surprising to many people, the most frustrating thing about a life with ALS was the inability to communicate. And he would get extremely frustrated when people would try to prematurely guess what he was trying to say or communicate. I think that we in health professional roles are often guilty of being in too much in a hurry, not giving voice to those concerns. And you really did a wonderful job of breaking these out into different themes. I want to invite people who are listening to this webinar to use the question and answer tab to post questions for Helen or any of our other speakers. And now we're going to transition to our second guest, which is Ethan Sperry. So he's actually in the midst of clinical duties and has prepared a video for us, but I'd like to tell just a little bit of his background. He is a clinician scientist and really just a remarkable individual. I had the privilege of getting to know him through the Tracheostomy Warriors site, but also because he was a medical student, just recently graduated from our medical school here at Michigan. He received his second tracheostomy in June of 2017, following years and years of worsening obstructive sleep apnea and refractory efforts to try to use non-invasive ventilatory support, such as CPAP. He's actually required 40 major surgical procedures to try to improve his face and maxillary and mandibular structure, to repair cardiac, structural, and rhythm issues, to address challenges with respiration, as well as ear surgeries. So as a lifetime patient and a student of the American healthcare system, he really brings a unique perspective. He was born in Alabama, grew up in Indiana, completed his bachelor's in Indiana, and then went on to graduate with an MD and a PhD from the University of Michigan, where his doctoral dissertation was in human genetics. He looked at the epigenetic and transcriptional regulation in a craniofacial disorder known as CHARGE. He's published quite extensively in the peer-reviewed scientific literature. He is doing a dual residency in both pediatrics and medical genetics at Cincinnati Children's Hospital Medical Center, and he aspires to an academic career. He's particularly passionate about improving outcomes and coordinating care for adults and children with chronic complex medical illness. So he's prepared a video about what to ask your physician about your trach prior to discharge. So now I'll turn it over to Amy to play the video.
Thanks, Michael.
Hello, my name is Dr. Ethan Sperry. I'm a resident physician at Cincinnati Children's Hospital in Cincinnati, Ohio, in the United States. And my specialties are pediatrics and medical genetics. And I have an extensive personal and professional history dealing with tracheostomies and airway management, and a lot of personal and professional interest in those as well. And I'm very grateful for the opportunity to be invited by Amy and Drs. Brenner and Pandian to speak at this panel. I apologize up front for not being able to be here in person, at least not for the first portion of this panel, as I'm currently on service caring for small children here in Ohio. But I know that I wanted to share some information and just kind of general observations that I've had over the last few years as I've gotten more involved in the tracheostomy forums and learn more about them and experience them personally as a patient and a healthcare provider. I entitled this talk, "My Doctor Didn't Explain This to Me," 4 sets of frequently asked questions from the tracheostomy forums and from Planet. And I think this talk will hopefully highlight briefly what are some big groups of information that we don't do the best at conveying to families and patients, and perhaps more importantly, why, or at least my very non-scientific, anecdotal experiences and thoughts about why we don't do a good job doing this right now. So a little bit about me before we get into the 4 question sets. I'm 33. I have a very complicated past medical history, as do many people with complex airway malformations, but my disorder is cerebrospastic syndrome. The ... are all the other millions of things wrong with me. And then critically, I've had about 40 surgeries, including 2 tracheostomies over the years. I was initially treated as a baby, and my parents had to manage that in 1989 from the outset, just like any other frightened new set of parents. And then I actually elected to have a trait placed back in me again several years ago now to manage airway abnormalities that I no longer wanted to have operated on. So I've had the unique experience of having a trait as both a kid and as an adult, and then also by making that decision to do this on my own, which is something I think a lot of people are lacking in this world, because most people get traits in emergency or near emergency situations. Anyway, I grew up in Indiana. My parents were both developmental psychologists, and my sister's a lawyer in New Mexico, clerking for federal court, working on environmental law and immigration law. I did my own college training at Indiana University in biology and chemistry, and then I recently finished both my MD and my PhD at University of Michigan. And I'm currently, like I said, a resident doctor at CCHMC, where I am getting jointly trained in both pediatrics and medical genetics. And I work with both Drs. Brenner and Pandian on trait research to some degree right now, particularly over the summer. And I focused a lot on genetics research projects, of course, during my PhD, and it's my primary research interest moving forward with my career as well. Although I must say my interest in tracheostomy care and management is growing every day as I realize how challenging it is for our families and patients. So I didn't have a lot of time to create this presentation, so it looks a little rough. I apologize. But there are really 4 sets of questions that I had outlined a long time ago, as I've been working on making kind of a brochure or a book on trait care. And these 4 classes of questions really highlight a reality, I think, for a lot of families, which is that they leave the hospital or they leave their first few appointments after getting a trait, and they don't know what they don't know, and they don't know what they haven't experienced yet. And there's way too much information for doctors to convey it all in a bite-sized, effective way. And we end up in this situation where they end up coming to the forums frustrated that they don't get answers to their questions quickly. And they often misattribute symptoms that are serious as not being so, and the other way around. And it creates a lot of, I think, morbidity and unfortunately even some mortality related to trait care. And I think it's really important that we recognize where we don't do a good job right now, at least what I've seen, both personally and professionally, and kind of think about it as what can we do to modify that. So the first set of questions that I have seen asked a lot about on the forums are trait changes. And there are lots of sub-questions related to this. How often can I reuse my trait tube? If so, how do I clean it? Can I do my own trait change? For some people, this is a reality, and it's a life changer for them. But for others, it's not safe. And then on top of that, we've got all of the people who need assistance with their own care for whatever reason. And empowering families to do this as well is really important. And I feel like this is a big group of questions that often get pushed aside early on in the trait discussion, because the first goal of any trait, a new trait, is first of all, don't touch it for 7 days. The ENTs are very firm about that. And then it's, let's do the first trait change. And then we'll do the next trait change down the line. We'll think about it later. We'll do it in 30 days. We'll do it in a week. We'll do it whenever. We'll do it based on whatever your insurance company says if you're an American. And the reality is that it's not a one-size-fits-all reality for people. I'm somebody who I hate having secretions build up around my trach. I I take my trach out every day and I clean it. And my stoma's secure enough to do that. Not everybody's that fortunate. But the reality is I've met people in clinic who come in and they've had the same trach for months. And it may be a physical reality of why they have to have it, with their insurance won't let them do otherwise. But the real truth is that they don't know any different. And it's not their fault, but it's just the system. They view the trach as this permanent object. And the reality is that there are a lot of variables that we don't talk about well with families. Another class of questions that I hear a lot about are the I can't breathe statements. Why can I not breathe in this situation? Why can I not breathe when I have to do this, or when I am sick, or what do I do if I can't breathe? How can I troubleshoot this? I don't have the energy to go to the ER again, right? I mean, there are levels of I can't breathe. There's the you can't breathe at all, and that's clearly a medical emergency. But there's a lot of the I can't breathe well, I feel crappy, and I can't make my life, like, I can't live my life the way I need to. How do I work on fixing that in the home? And the truth is that this is a very complicated physiologic problem, and we don't fully understand it, to be honest. Lungs are crazy complicated, and they're also really simple at the end of the day. They're literally just bags, but the physiology behind them is remarkably complex. And the truth is that we have all sorts of things that I know I wasn't taught about until I had my own trach. Even as a medical doctor being taught about trachs, I didn't learn about a lot of this. I certainly didn't learn it when I got my trach. But things like humidity. Is it okay to always have humidity? Or maybe some people don't need it all the time, right? Maybe there's a Goldilocks humidity to think about. What about suctioning? Do some people actually have a negative consequence of suctioning too much or too little? Some people don't need it. Some people need a lot of it. Some people need different types of suctioning. Then you've got infection. What do we do when it hit a mild infection? When does a mild infection become a complicated infection? Some children, some adults are so immunocompromised that any infection becomes a medical emergency. Most people aren't that way, fortunately, but it really does change how we think about things. How frequently do I need to change my trach when I have an infection versus when I don't? Is that something that matters? Right? These are all things that are brought up all the time on these forums, and there aren't any consistent answers for a lot of people, and they certainly are being discussed easily in the doctor's office. And then there's all the troubleshooting. When do I stay home and work on it? When is this an emergency where I call EMS, or something in between, where I drive to the emergency room? And then we've got the special situations, the patients on vents. What does it mean to be on a vent? How does it change all of this? There's so much complexity. And my point with this slide, on top of just introducing these topics and complexity, is to make everybody kind of think carefully about, these are all things that I think a lot of providers go, oh yeah, of course. But the actual details, to somebody who doesn't know or have the confidence, for good reason, doesn't have the confidence to troubleshoot and trial and error and do little experiments at home, I mean, it's literally life or death for them. They have to decide to do this or not. Do I suction or not? Do I turn my humidity on or not? I've given so many patients over my time as a medical student and a resident permission to try different humidity levels at home. I think it's something that we do a really bad job of in general, is teaching people that humidity is not a one size fits all. Everybody's got different needs. Everyone's bodies are different. And it's really important that we think about that as we go forward. And the point of that then is to realize that this is complicated, it's hard, and it's going to take time to get these points across to families. And we have to recognize that trach management is a chronic problem that requires chronic follow-up and close follow-up. And I think especially in the United States, we tend to kind of put the trait in and then send people home with their DME, durable medical equipment script, and then once a year you go in and see your doctor. I know that's how it happened for me, and that's just not effective for a lot of families. And that brings me to the whole supplies thing. I mean, this is an issue that's more prominent here in the United States, I think, than in many of the countries that have better or at least different forms of healthcare. But I mean, the whole question's about what supplies do I need? How do I hit them? What should I expect with the supplies? What happens if the supplies change? Barb Bosworth will probably talk a little bit about this and her work with Medtronic. What happens if I get sick, use more, need an early refill? Who do I contact? And then probably most critically recently, what happens when there just aren't any supplies to have? What can I clean and reuse, even if it's not ideal? What can I do to make that faster and better for me? And kind of the last question I always see is like, oh, I just coughed up blood. And you can add in any, like people coughing up colored sputum or people who right, you can put any symptom you want. Blood is the most dramatic that we typically deal with. But this is just another thing that takes something simple like you cough up blood, your first thought is usually, I'm going to go to the hospital, right? I'm going to call my doctor. But the reality is, for someone with a trait, this changes. Plus, blood is normal or normal-ish for people with traits at certain stages of their trait experience, as well as with infection and other things. I always cough up blood when I get COVID. I've had COVID 4 or 5 times. And I always cough up a little bit of blood. I know enough to know that it's not a serious amount and I'm going to be fine. But blood is one of those things that looks way worse than it often is. And we do a really bad job, even something this straightforward almost, of educating families on how that changes with their trait. And again, the whole idea of helping people triage, giving people this information gives them their autonomy back, and it gives them the ability to take more control over really financially critical decisions, especially here in America, with regard to like, how do I go to the ED? And this can be the difference for a patient between the trait being something that they live with and function around versus something that becomes the sole thing that they exist with and for. It's so intense to manage that it consumes them. And those are the patients who have really poor outcomes, at least with all the medical and psychological concerns that come with having chronic illness. And I think we generally don't do as well as we could with all of that. So in summary, this is all anecdotal, and I want to acknowledge that it's not really up front anymore, but at the end of this, I want to acknowledge this is just anecdotal. I don't have data for any of this. I can tell you though that there are trends, and those trends are real, and they have persisted for me, both personally as well as professionally, in at least 2 or 3 different environments and hospital systems. And then anyone go on the Facebook groups and just see the discontinuity between what they're told and what they hear and what is true and what's not. And it's no one's fault, explicitly. It's certainly not the patient's fault, but it reflects a extreme challenge that we face in the community. And I have identified a few possible reasons, kind of classes of reasons. One of them is that a lot of these issues are never discussed. This is a lot of information. I think we have to recognize that. It takes a lot of time to convey it, and it's not fair or even reasonable to ask a patient or a physician or another healthcare professional to sit down in one sitting and go through everything. And it's not really reasonable to hand them a 100-page handbook and say, here's all the information. Because everyone's individual experience is just that, it's individual. And we as healthcare providers have to recognize the individuality of this and recognize that everybody's going to need a different set of information. And that, again, highlights this is information overload. There's a lot of information. It took me months to wrap my head around the changes that happened to me that were ongoing for the first few months after I got my second trait. Then there's also just general provider-patient misunderstanding. Provider thinks the patient heard that, patient wasn't even paying attention because they're overwhelmed by the whole idea that they're in the doctor in the first place. I remember a lot of people with traits, related traits, as they get diagnoses like cancer. The trait becomes a very secondary problem initially when you're worried about whether or not you're going to live. And it's just, those are all the complexities of what goes on. And I mean, think about the children. I've watched many families give them advice about their very sick child, and their other children are busy eating and throwing Cheerios across the floor. There are so many variables, and it's so critical that we set aside a place and time to communicate this important information, to do it repeatedly. And another really big problem, at least in America, is the discontinuity between providers. The person who placed the trait is often not the person who follows up with the patient long term. And this is a huge problem. And it creates a lot of logistical nightmares, particularly in the United States. But it also just creates a trust issue between the patient and their family and the healthcare system as a whole. And we need to do a better job in the community of creating trait clinics that really support both children and adults. And I mean, again, this is primarily more of an adult side issue that I've seen, although I have only ever practiced at massive children's hospitals. I think my story would be different if I was practicing in a more rural children's hospital. But we definitely do a better job in the pediatric environment for this, if only because traits are more common in states. But we definitely fail miserably at this in the adult population in general. And then this also kind of links with that, but different medical systems place trait management in the wheelhouses of different specialties, pulmonology, ENT, some of them do PM&R. And it's just really complicated. And I mean, it's a maze to work through, and I'm a doctor. I mean, doctors can't figure this out. I've asked doctors, where do I get this supply? And they look at me like I am speaking in some alien tongue. It's not functional for them. And it really becomes a matter of developing consistency, I think, between hospital systems and within the professional medical communities that we're a part of, to really highlight how we can be better at this. And finally, again, to kind of reiterate, a trait is a major life adjustment. It requires close follow-up. Parents and patients and families are going to have new questions as they serially experience the aspects of having a trait. They don't happen at once. My trait experience has changed over the last several years. Everyone I know has a different perspective on how a trait affects them a year out from a day out. I don't have the dissection requirements I used to have. I don't have the infection issues I used to have. My stoma is secure now compared to where it was. It changes how we think about a lot of this stuff. I would never in a million years have advised in me coming right out of trait surgery to clean my trait every day. I would totally do it now. As a doctor, I would feel comfortable advising me as a patient to do that, and I do it. And it helps protect my airway, keep me healthy, and allow me to be more comfortable with my trait. But it's not safe for me to do that 4 days after trait surgery. And it's those details that get lost in the shuffle. And it's imperative that we as a community work towards being more consistent and more willing to meet with people more frequently, and to really create a welcoming environment for patients to have an opportunity to answer or ask them the answers to these questions. Anyway, thank you very much. I'm sorry I couldn't be here in person, although I hope I will be able to be here at the end of my shift here. We'll see. If I'm not here, I apologize. My contact info is here. You can always email me. And I'm always looking for opportunities to work with research around trait and trait management. But anyway, if I do come online, at the end of my shift, I'll be happy to answer any questions. If not, shoot me an email and we'll go from there. Thank you so much. Bye.
Thank you, Ethan. Over to you, Michael.
Terrific. If somebody could unmute my video briefly, I'd like to introduce Barb Bosworth. This is a nice transition from Ethan's presentation. Ethan is, I'm sure you could appreciate, is a really deep thinker, takes a very scientific and evidence-based lens to the challenges of living with a tracheostomy. And I think that even from his anecdotal experiences, you can see many of the challenges that generalize to many other individuals. So now I'd like to present Barb Bosworth, who has simply been a phenomenal fixture in both the tracheostomy forums as well as a professional. She's a retired RN and is the moderator for the Tracheostomy Warriors Facebook group. And she's actively involved in no fewer than 10 tracheostomy Facebook groups. Barb was kind enough to share a little bit of her story that I'll relate here. She, much like Ethan, who we just heard from, chose a tracheostomy. And in her case, that was about 20 years ago in 2002. And the reason for her was severe obstructive sleep apnea. CPAP would not keep her airway open, so she researched many options and found that a hood stoma stent would work perfectly for her and opted for a skin-lined formalized stoma that she would not, where she wouldn't have the raw tissue and concerns about the stoma shrinking. But it turns out that she had a fairly harrowing experience about 6 years ago. So she went back to work full-time after having her tracheostomy, which worked fine for about 14 years. But about 6 years ago, she noted that there was more granulation tissue that was forming around her stoma site. And basically the 13mm stoma that she formerly had, which was her lifeline, was closing to a 1 to 2mm slit from granulation tissue. And eventually she found that she wasn't moving any air at all, in or out. And after about 3 minutes, she started pounding on the wall. And thankfully her husband was in the next room and heard her. So he rushed into the room, tried to give her mouth to stoma ventilation, which didn't work. And then in a moment of brilliance, he actually ran to the kitchen and grabbed, of all things, a Slurpee straw, jammed it into her stoma and got her breathing again and called 911. When Barb woke up in the ER after all the tests were done, she actually had no brain damage miraculously because he had acted so quickly, and she now has a Shiley 6 XLT proximal. So what Barb's going to talk to us about kind of dovetails nicely with that story, which is about what's involved in leaving the hospital, returning home, and making that transition. She's going to touch on the considerations needed for discharge to home and the education that patients and families need. Finally, she's going to discuss about building a community and peer connections. It's my pleasure to introduce Barb Bosworth.
Thank you, Michael. So I've been on Facebook trach groups for about 5.5, 6 years now. And it's really amazing. I've learned, of course, more about having a trach, more about trachs by having one than from, decades of working as a nurse. And so in following on Facebook, a lot of people's posts, I noticed a lack of patient teaching, as Ethan was just talking about. As far as, care and troubleshooting. And so again, Facebook has about 12 different Facebook trach groups and another 12 for infants and kids. So if you're on Facebook, just search and type in tracheostomy and several groups will show up. The most popular is Tracheostomy Warriors. And the second group that actually has more members is Tracheostomy, but that includes parents of kids. So that's why it's much larger. I will note that I check on the members a couple times a year, and for Tracheostomy Warriors, the participation has grown by about 800 members, and quite a few are post-COVID survivors that have now joined the Facebook trach community. So as you can see, there are several, and a lot of them are located globally. Some of them are specific for the UK, although many global members belong to these groups, even though they don't live in South Africa or the UK. We're all just kind of a global community here. So online, you can find policies and procedures from major hospitals, but people need direct user-friendly advice from people who live with trachs. Facebook's not to be taken as medical advice or as a replacement for your doctor, but this platform is more personal and practical. Sometimes we need to improvise with the equipment and supplies that we are given. And right now there's supply chain issues, so this has become more of a ongoing issue for some people when they're down to just a few days left of supplies, and their DME calls them and says, "Oh, you're going to have to clean and reuse these now." And it's like, what? So the average person does not fully understand their bodies. Someone posted their concern that if they were breathing through the neck, how was the brain getting oxygen? And they're not dumb, but just lack of understanding of how the body works. And some people also assume that, because you have a trach that you can no longer eat. And that's not true for most of us with trachs, but it's true for some. So one thing that I've noticed there are a lot of people having issues with is what's called deep suctioning. And so a lot of people, you don't want to go in too far. As you can see on this diagram here, is about halfway down before it splits into the carina. If you touch the carina with a suction catheter, it is not very comfortable. So what you should do is you should check the length of your trach tube. It should be printed on the faceplate or on the box if you have an extra tube box around. And then look at your suction catheter. You only want to insert the catheter to just past the end of the trach tube. Because again, if you touch the carina, not going to be comfortable. So for those who have intercannulas, so the trach tube, this is a 6XLT. So the measurement is going to be basically from where the hole is, the stoma, down to the tip of the tube. But you can see there's an extra inch between where your neck opening is and the actual trach tube. And then when you add an intercannula, you're adding an extra inch or 25 millimeters. And so you need to be aware of how much distance you can safely pass through the trach tube in doing your suctioning. So most trach tubes, and I'm giving an example of the size 6 in a Shiley. Most trach tubes for adults are about 3 inches. The XLT that I have here is 3 3/4 because it needs the extra length for certain patients. So again, the tip, where it exits into the airway, is only going to be less than 2 inches. So you can't just blindly keep threading the suction catheter until you hit something, which is the carina. So again, you need to be aware of measurements. And it's sometimes in the hospital, they'll post on the wall, how far to go in with the suction catheter. And this is the measurement that should be shared with anybody who is doing suctioning. So, and you'll find too that people who are shorter have a short airway, and taller will have a longer airway. So this is a big issue for a lot of people, is they just need to know how far to go with a suction catheter. So the other thing too is people don't understand where the trach tube goes. They think, again, you can't eat because it's passing through the throat. So your throat, actually also called the pharynx, shares 2 body systems, the digestive system and the respiratory system. And the food and drinks pass through the throat and into the esophagus, stomach, intestines. And the throat also shares the air that you breathe in and out. So there's a flap called the epiglottis, and you can see that on the diagram here. And that closes to prevent food or drink from entering the airway and the lungs. So the other interesting thing too is the back wall of the trachea, the airway, is also the front wall of the esophagus. So unless there is a hole, also called a fistula, there should not be any food entering the lungs. But of course, it can happen if you eat too fast and food goes down the wrong way. Or if you happen to have food poisoning and you're throwing up a lot, aspiration can always be possible. So, but usually, if you eat too fast, you cough, and that prevents things from going into your lungs. But again, if you're prone to having aspiration issues, you need to be aware of that, modify your eating, slowing things down, not talking while you're eating. So things like that. So again, a lot of things comes down to understanding your body. And it's difficult for somebody who doesn't have a background and has learned things about anatomy and physiology and things like that. And this is normal and it's common, and we need to explain these things to people. So again, there's lots of resources out there. I've been very impressed with Facebook. I'm on there several times a day, the various straight groups. And it's nice to share experiences and to be with peers that understand what's going on. And so again, these are great resources, kind of unconventional for some people, but for others, there are all ages that I have found on the Facebook trade groups. So again, I hope this has been helpful, and thank you.
Thanks for a phenomenal talk, Barb. That was really illuminating, and I think it shed light on a lot of areas that are easily confused and misconstrued. Super helpful and instructive, and also for just being such a wonderful resource for all the people on the Facebook pages. I think there's such a tremendous craving and hunger for knowledge, and the way that you explain things, it really kind of shines through your natural gift for teaching and communicating. So our next guest is Karen Ulmer. Karen Ulmer, MSN RN, is one of the most special, wonderful people you'll ever meet, which is why we saved her for the end. She has a specialized certificate in otorhinolaryngology and has worked as a ORL nurse for 30 plus years. She began her career as a staff nurse on the inpatient ORL head and neck unit, and she served as an otolaryngologist nurse specialist at Milton J. Dan's Junior Head and Neck Center at Great Baltimore Medical Center since 2004. So a lot of really terrific experience under her belt. She's very active both on the local and national level in the Society of Otorhinolaryngology and Head Neck Nurses, and has been part of that organization since 1993. I had the pleasure of meeting her in Philadelphia, courtesy of Vincia, who serves as president of that organization, who also joins us on this webinar. And she just simply amazed me in her ability to communicate and connect, and as a leader. And maybe most amazing was that after one of the formal events, they went out to a very loud social event that I wasn't able to project my voice over, but somehow Karen is so passionate about communicating, managed to actually carry on a conversation. So Karen has had a tracheostomy for over 20 years. I think she actually recognized her 21st year. She enjoys working with with patients, helping them identify how best to integrate tracheostomy or laryngectomy into their daily lives. And really her goal is to help patients not just live, but thrive with the tracheostomy or laryngectomy. So it's my pleasure to introduce Karen Ulmer.
Thank you, Dr. Brenner. Full disclosure, as Dr. Brenner said, I am a nurse and I have a trach. My primary patient population is head and neck cancer. So many of my patients are functionally independent at baseline, and therefore my goal is to get them to be functionally independent after surgery and treatment. As a nurse, it's really important that I confirm my patient's goal, which may or may not align with my goals. Areas that we need to consider with our patients: independence or functional limitations. This is a place where we might use our occupational therapy colleagues to help us come up with some sort of custom adaptive device that can help patients be independent. Barr mentioned about knowing how far to suction. One of my patients was blind, and so he was a very tactile adapter. So we ended up using what I call a mostly clean technique, where he measured the suction catheter over the length of his hand, maintained his finger at that length, and then knew how far to advance the catheter in order to independently suction. ADLs is another area we need to look at. Sense of smell is compromised, so we might recommend that folks get a natural gas detector. One of the questions I get when my patients are in the hospital is, can I take a shower? And I have a one-word answer, please. And that usually breaks the ice, and then we go over, strategies to make showering safe. Using a shower wand, using a shower shield, body positioning while bathing. Communication, if people can wear a speaking mouth, that's great, or use a GEP prosthesis. Otherwise, there's talk or type to talk apps, and then different low and high tech communication options. Again, where we utilize our speech pathology colleagues who are absolute experts in that area. Family and community support, again, can't underestimate the value of that. And then hobbies and leisure activities. Too many people think that they cannot resume their normal activities. And other than water sports, there's really not much that you cannot do. But you probably do need to make some adaptations. I've had people that are avid bicyclists, and then they've worked with the cycling area to raise the handlebar to make it a more comfortable position. I'm married to a redneck, they're hunters. So I have patients that like to hunt in this cold, dry air when they're hunting. So maybe a balaclava, something to make a pocket of warm air to breathe while they're out in the woods. And then I was asked to consult a patient from one of our laryngologists, and the patient really loved the fence. But the fencing on would get snagged on his trach tube. So he admitted that he took the trach tube out when he was fencing. So we ended up converting him to a low profile trach tube so that he could actually maintain a safe trach site while he was fencing. My next topic I want to talk about is, of course, COVID, or really just infection prevention. I'm not talking about what to do when someone with a trach has a COVID infection. That is a completely different lecture. But really, a lot of the infection prevention is common sense. Wash your hands, avoid sick people, disinfect. Make sure that you're up to date with your vaccination. The COVID vaccine is considered safe and recommended for medically fragile individuals. However, there's a caveat. Any questions or concerns for you or your family member, talk with your physician who knows you better. Wear your mask. So a standard HME is considered an artificial nose, but that does not adequately provide filtration for bacteria and viruses. So the mask should have one for the nose and mouth, and then another one over the tracheostomy site. There are HME filters that do provide filtration for bacteria and viruses. They're usually labeled HME-F for filtration. and they are electrostatic filters that reduce the inhalation of airborne particles via the stoma and then protect others while you're exhaling. And those are just two that I'm familiar with. There may be others out there. Most of the information on this slide comes from the TSA website, but it's always a good idea to contact your airline if you are applying for any specific instructions or requests that they have. Most of us know that medical devices and supplies do not count against carry-on luggage. So you just need to make sure that whatever that extra bag with supplies is solely for medical supplies, not having any personal items with it. You want to make sure that you declare any items before you go through security. It's not required, but a lot of my patients will have me just write a basic letter and detailing their medical history, their medical supply needs, and why it's necessary, sort of as a safety backup. I haven't flown since COVID, but I always found out that before COVID, I got pulled out the side for an extra pat down to allow extra time when you're traveling. You may want to ask your primary team for referrals to providers in your destination. For our laryngectomies, if it's coming up on about timing for them to have their TAP replaced, we might do that prior to them traveling and have them travel with an extra one, as well as providing them contact information with the speech pathologist in their destination area who has the expertise to replace the TEP prosthesis if needed. And then again, going with your common sense, bring extra supplies. It's always better to have more and take it home than to not have what you need and not know how to get it at a different location. So my husband doesn't know that I put a picture of him in here. This is one of my favorite tracheostomy necklaces. So a lot of people, you still want to be fashionable or not noticeable that you may have a trach or laryngectomy. So there's a lot of different options for wearing to cover the trach site. So scarves, everyone's wearing scarves today. I'm wearing one today. You know, that's a nice way of camouflaging the area. There are Dickies style ascots that can be tucked inside of the no-fit button down for the gentleman. There's a lot of trach jewelry. If you go on Etsy and just type in trach jewelry, everything between chains for, securing the trach tube, cutesy trach dressings for the pediatric patients. And then web whispers, which is primarily for laryngectomies, but they have a lot of really good resources that also can apply to people with the trach tube. So that's another really nice site to try to find other information. And then the next thing would be to don't assume you can't. Many of you may recognize Michael Phelps. He's from my hometown, so I had to include him. And I think a lot of his golden rules for success really kind of apply to people that have a trach tube and what they need to do to get back into life and be successful. I think you have to really identify your goal. What do you want? And then go for it. Put everything into it, have a plan. In the the healthcare, we're always talking about the PDSA cycle, plan, do, study, act. And then once you see what works or not work, make a revision and then try that out. Have a team. This is so important. We really need to take advantage of everybody. Our patients, their family members, the physicians, the respiratory therapists, occupational therapists, speech pathology, nursing. Take advantage of all of the experts that surround you and use them to help you achieve your goals. Stay motivated. You're going to hit speed bumps and things that don't go well, but continue to try and try again. And then celebrate all of your successes. Your successes may be little. I know with the old Charlie trach tubes, it was very difficult for a lot of patients to remove and replace the inner cannula. So when they first went home, they had to have a family member. So it was a big success for them to be able to independently manage that part of the trach tube and then not need 24/7 supervision. And then my next slide is another Baltimore favorite. And this young man did not have a trach, but his infectious personality and habit of making the best of his circumstances are a lesson that we can all apply to our lives. Mo Thomas' first diagnosis with cancer was at the age of 9 months. He soon became blind due to retinoblastoma, which he had another 2 recurrences. At the age of 6, he had osteosarcoma. Even as his life was ending, he was not focused on himself, and he was focused on what he could do and giving back. He reached out to one of our baseball players who was diagnosed with colon cancer to offer him hope and support. Trey Mancini said that throughout his battle with cancer, Mo never lost his kind spirit or his sense of humor or his love of the Orioles. His courage and unwavering positivity in the face of challenging circumstances have made him an inspiration to me and so many others. So Mo obviously had a lot of limitations. He was blind, he had very limited mobility, but he didn't focus on what he could not do. He found joy in what he could do. And he's known as Baltimore's greatest sports fan. He passed away just over a year ago at the age of 14. But Mo showed all of us that when the going gets tough, you get tougher, and how to find joy in your life. And I think that's something that all of us with the trach or caring for someone who has a trach is to focus on what we can do and find joy. And that is the end of my presentation. I'm hoping we have a little bit of time left for Q&A.
Thanks so much, Karen. That was absolutely fantastic. I learned tons of things. I didn't even know what an ascot was before your talk. And I think you probably drummed up a lot of business for the manufacturer of that necklace that you showed. That's beautiful. And you know, there is a lot of resources there that we don't think about so much, but the logistics around traveling is something that everyone with a tracheostomy absolutely needs, as well as the inspiration that you brought to this talk. I'm going to actually just kick off the question and answer portion of our discussion. This is actually a nice segue from some of what you were discussing about humidification. So this one comes, and I apologize if I mispronounced the name, from Alyssa Sikrowski, who I believe is a respiratory therapist in Chicago. So she writes, your comments on humidity are something I'd like to look into. My patients commonly struggle with finding the right temperature in humidity setting. On the heaters, you can adjust both. Some heaters only have 2 heating settings. Do any of the panelists have recommended literature or studies or even just practical advice regarding this particular question of how to optimize humidity and temperature?
I'll jump in. Like Ethan said, I think it's very patient specific. Off the top of my head, I can't cite, but a 40 to 50% humidity is kind of thrown out as a general ballpark starting point. But I think a lot of it depends on, the quality of the patient's secretions, how loose or how thick are they? If they're thick and they're tending to mucus plugs, then they probably need a little more humidity. If they're very watery and copious, you might be able to back off a little bit.
Thanks for those insights, Karen. And thank you, Alyssa. We actually really value the engagement of respiratory care practitioners in this forum and all the different allied health professionals and partners in efforts in tracheostomy care. I don't know if I can call on Barb for any insights on this question as well, or other panelists. Okay.
So I use a humidifier every night, but I don't use one of the compressor types because they're very noisy. I've kind of jerry-rigged a commercial humidifier that directly connects to my trach mask, and that works great for me. I noticed in the hospital, if you're on a vent, they have warm settings, but if you're just on oxygen, it's a coolness. So and I really do not notice a difference in the heat versus coolness. I do not use the heater on my humidifier, basically because I don't want the tank to start growing things. So everybody's kind of an individual in their taste.
Terrific. That's super valuable. I'm going to hand it over to our wonderful host, Amy, who's just done a phenomenal amount of work in getting this session together.
Thanks, Michael. Thank you, everyone. I've got another question. I think what really resonated across everyone's presentation is individuals and individual needs, and really listening, not just hearing, but listening and attending to those needs. And just a couple of the comments from the audience as well about highlighting the importance of partnering and working with families and people with tracheostomy. I just want to throw a question to the panel in terms of discussion about how we work with people with tracheostomy, with families in terms of care needs, equipment needs. So Vanessa has highlighted in the UK that equipment can be limited as well. And what's your advice about going forward? How do we engage and really truly partner with people with tracheostomies and their families in terms of a key takeaway from your viewpoint? So maybe we'll start off. Karen, do you want to start off?
I know at my hospital, I'm an individual member of the GTC, but the hospital itself is not. I, especially in the beginning of the pandemic, was sharing everything from the GTC with everyone in my hospital. And should there be a way to reach out and connect with staff members who are not in member hospitals, that might be helpful, because there are probably individuals who are very interested, but for whatever, and probably financial reason, right now the hospital is not a member.
Thank you. So really about that community, joining a community of practice where you can link in with other centres and learn from some of their journeys and what they can do. Yeah. What about Barb? What are your insight and takeaway in terms of how we really do meet needs and partnering with people.
So, you know, especially in the United States, insurance kind of dictates what we can and cannot have, when we can have things. So it's interesting too, in talking with Medtronic this summer, they were amazed that because the FDA has a 29-day limit of any non-implantable devices, that our insurances will make us wait 3 months. And they were very surprised by that. But it's kind of like, well, this is what we get. So that's very confusing because, you know, this is an FDA requirement, but yet it's not being followed.
Yeah, a lot of
Thanks, Bob.
you know, I would actually like to double back to some of the themes that Helen mentioned in her talk. One of the interesting things is that some of the individuals on our panel are part of the Trach Warriors group, and it's sort of an interesting name, and perhaps we'll get a little bit of the history on how that came to pass. But I was wondering if among the themes that you encountered in your meta-analysis and study of experiences, if there was an ethos of actually being in battle or feeling like actually one was a warrior. Was that something that came up in any of your research?
Yeah, so we just looked at the ICU related research, but there was definitely a lot of anger, and it felt like people were fighting to get heard and get control and be seen. So although it was, I suppose, very much an individual battle at the stage of being in ICU as a patient with a new tracheostomy, so it's probably slightly different challenges that the people in my study would have been facing. But there were a couple of papers that actually did have information about longer term experience and going home and living with long-term mechanical ventilation. And then you've got the issues of carers, changing carers if people are dependent on external care agencies for their tracheostomy and ventilator support. And it's the whole fighting to keep your identity, be seen as a person, not just a job for someone to come and see. So yeah, I think definitely there are challenges and fights, but probably changes through the journey of having a tracheostomy. I don't know what Barb and Karen would say.
Well, that is really interesting, that notion that a shared identity and sense of community is probably something that people don't have the benefit of in the ICU, and that probably emerges as people go out into the community. So yeah, I would love to hear from Barb and Karen or Vincia just on that perspective and evolution. Maybe Barb first as the moderator. Maybe you can moderate that part of the discussion.
Well, I remember in nursing years ago, I think there was a volunteer group called Make Today Count that were breast cancer survivors that actually made patient visits to the hospital so they could speak one-on-one, you know, as a peer. And that's one thing I think that Facebook has kind of brought to the table, because obviously we can't go into the hospitals because, you know, of HIPAA and infection control and things like that. But, you know, a lot of people are not online.
From my perspective, so we have a patient and family support group through the Milton Dance Head and Neck Centers. So my patients who are discharged with the tracheostomy are invited and able to attend that group. Not everyone has a treatment. Most people actually have non-surgical treatment, but we've had a few people that have tracheal laryngectomies that will attend that group. If we are anticipating someone's going to have a tracheostomy as a result of their cancer surgery, we try to either bring them in person and go over, you know, pre-surgery what's happening anatomically, what they're going to see, heal, feel when they wake up, and then what the nurses are going to help them do in order to get them home. Our laryngectomy patients actually meet someone who's had a laryngectomy who can actually tell them from someone who's been there, bought the t-shirt, you know, what it's like to live with laryngectomy.
Thank you.
Oh,
Thank you so much. Oh, sorry, Cynthia.
No problem. I was going to chime in and answer the question that Michael asked earlier about the name Trach Warriors. So I had initially started a tracheostomy support group within my institution and invited several people. They said they would show up. I think about 13 of them said they would show up. I had snacks and everything ordered and ready to welcome them. Not one person showed up in person. And that's when I realized that there are many factors involved with getting trach patients transported to a place. So that's when I was motivated to start this Facebook group. Initially, it was just called Tracheostomy Support Group, but it was the members of the support group who reached out to me and said, we're all warriors, we're all survivors, can you rename it? So it was actually the members of this group who came up with the name Trach Warriors.
I love that. It's you know, really looking at what people want, and recognizing that journey as well in terms of being warriors. What I would like to do, unfortunately, we've run over, so we'll need to close the panelists, but also just giving a shout out to those audience members that have contributed to the panel. So thank you very much, Shirley and Svenja as well, for your comments, and Tanner. So thank you for contributing and listening in. So just closing our webinar, just wanted to highlight a couple of I guess research that the different group members are involved with. So this is a survey that's open at the moment. So it's about when people, so any member of the multidisciplinary team is developing an intervention, what should they measure? So what is important to measure? So as we clearly heard from different panelists, what's important to one person may not be the same to another. So especially the views of people with a tracheostomy, their families, and different clinicians. So there's a QR code there. So if people would like to know more, if they would like to participate and like to vote about what's important to include, please feel free to scan that. So I'm one of the co-leads for that project with Professor Louise Rose. So please also reach out and email if you have any questions. There are a couple of other surveys as well in regards to neck breathers that will be coming out. So, but we'll follow up with some further details in an email just about those different projects you choose to be involved. Our next webinar, so mark your calendars, is going to occur in November. So it will be for those in the Northern Hemisphere on Wednesday, the 2nd of November. For us down in the Southern Hemisphere, it'll be on Thursday. And we'll send out some details earlier on so you can register nice and early for that. As with all of our webinars, we record them and we post them up on the GTC website, which is the link there to our GTC. That's a wonderful platform, web platform that has all of our resources and in terms of our educational webinars. So please feel free to go there afterwards. Thank you again very much for your time this morning, and a big thank you for the panelists for presenting and sharing your work and your stories today and in preparation. So also acknowledging Dr. Brenner and Pandian for your help. So with that, I'll close off and wish everyone a good night or good morning. wherever you are. Bye now.